Good afternoon, everyone. Bonjour tout le monde. Um, we have the privilege of introducing you today to Mireille Guillot, who is an assistant professor in the Department of Pediatrics, a neonatologist, and a clinician-scientist at the CHU de Québec, Université Laval. After completing her pediatric residency and neonatology fellowship training, she completed a research-intensive fellowship in neonatal neurology at the Hospital for Sick Children at the University of Toronto. In parallel, she completed a master's in epidemiology at the University of Toronto. Her research focuses on identifying modifiable risk factors in the neonatal period, including neonatal nutrition to improve brain development and long-term outcomes in children born preterm. As an early career investigator and FRQS Junior 1 Research Award recipient, she is building a rapidly expanding research program in close collaboration with experts in perinatology, neurodevelopment, hemodynamics, and nutrition. Welcome.
Thank you. Thank you very much for the introduction and the invitation. So today I'll be discussing omega-3 supplementation in very preterm neonates, focusing on DHA and what I call the DHA dilemma. Before we begin, I would like to disclose that I'm supported by a FRQS Junior 1 Clinician Researcher Award, for which I'm super grateful. So these are our objectives for today. So by the end of this talk, I hope to do three things. First, to revisit the biological rationale for omega-3 and DHA supplementation in very preterm neonates. Second, to critically review the evidence across trials and meta-analysis. And third, to identify key knowledge gaps and future directions. So this is our plan. I will start with the clinical context. We will move into biology, then spend some time reviewing the evidence before finishing with interpretation and future directions. So first, the clinical problem. So before we go further, I think it's important to define who we are talking about when we talk about very preterm neonates. Very preterm neonates are those born before 29 weeks of gestation. And these neonates represent one of the most vulnerable population in pediatrics. You can see a picture on the right side of the screen of a baby born preterm at around 24 weeks gestation. And what you need to know is that these infants require support for breathing. You can see that this baby has a breathing tube. Sometimes they need a mask to support their breathing. They need support for feeding. They need support for thermoregulation. Here you can see that this baby that was just born is in a plastic bag because we want to keep him warm. And this baby will be in an incubator for several weeks after birth. And these preterm neonates are exposed to a range of complications that we will discuss shortly. These babies are exposed to inflammation and oxidative stress in the first weeks of life. And you will understand that this concept will become relevant as we discuss about the role of omega-3 for this population. So in Canada, we've seen major improvements in neonatal survival over the last decades. What this graph is showing you is a constant improvement in survival between 2004 and 2017 on the x-axis. And this improvement in survival is seen across all gestational age. The green and the yellow line here represent the most immature neonates, those born less than 29 weeks. But while survival has improved significantly, morbidity remains high. So these neonates are at high risk of several morbidities, including bronchopulmonary dysplasia, or BPD, the chronic lung disease of prematurity, eye problem with the retinopathy of prematurity, what we call ROP, They are also at increased risk of brain injury and long-term neurodevelopmental impairment, and at risk of problem with their gut as well, with neck, that we will not discuss today. So what you need to know is that the clinical focus has really shifted for this population from increasing survival to increasing the quality of survival. And a crucial question, especially for me as a neonatologist caring for these neonates, is what can we do differently? What modifiable factors early in life can influence these outcomes? And among the modifiable factors, nutrition stands out as a particularly promising target. And this is a central area of my research program. So today we will focus on neonatal nutrition and more specifically on the role of DHA or docosahexaenoic acid, an omega-3 long-chain polyunsaturated fatty acid. So let's move on to the biological rationale of this DHA. So first thing first, what is DHA? As we just mentioned, DHA or docosahexaenoic acid is an omega-3. And DHA plays a critical role in brain and retinal development. It also modulates inflammation and oxidative stress, which are pathways involved in several neonatal comorbidities. Importantly, as we will discuss later, DHA interacts with other fatty acids, including arachidonic acid or AA, which is another key long-chain polyunsaturated fatty acid. So why DHA matters in preterm neonates? Well, the key issue with DHA in preterm neonates is that most of DHA is transferred from the mother to the fetus during the last trimester of the pregnancy. And when a baby is born very preterm, that transfer is abruptly interrupted. So the fetus miss this critical window of DHA transfer. So these neonates are born DHA deficient. And that's where the idea of supplementation comes from. If we replace DHA postnatally, can we improve outcomes? And before diving into recent trials, I think it's important to understand how the field has evolved over time. The earliest studies in the 90s were not designed to replicate what the fetus would normally receive in utero. Instead, the goal at that point was really to match the DHA content in human breast milk. So in these studies, they used relatively low doses of DHA, around 0.3 to 0.4% of total fatty acids. And these studies were conducted in broader populations, including both term and preterm neonates. And they actually suggested some benefits, particularly for visual outcomes. But the designs and the outcomes were very heterogeneous. Importantly, based on these studies from the 90s, the preterm formula was modified to routinely supplement with low dose of DHA, around 0.3 to 0.4%, starting in around 2000. And more recently, the field really has shifted. The focus is now on mimicking the placental transfer, what the fetus would have received during the third trimester. So this has led to a much higher dose of DHA, what we call the high dose DHA, where we are targeting more than 1% of total fatty acid. At the same time, studies have become much more targeted, focusing specifically on very preterm neonates who are more vulnerable to DHA deficit and at higher risk of adverse neonatal outcomes. Therefore, they were more likely to benefit from a high dose DHA supplementation. Now, one important thing to highlight is that in utero, DHA is not transferred alone. In fact, both DHA and arachidonic acid accumulate rapidly during the third trimester. So when birth occurs early, this transfer is interrupted, and these neonates are not only deficient in DHA, they are deficient in both DHA and AA. And while this might sound like a detail right now, you will understand that this DHA-AA balance might be important for clinical outcomes. So why AA matters? Well, arachidonic acid, or AA, is a key omega-6 fatty acid, and it plays a critical role in growth, brain development, and immune signaling. And what you need to know, and I will highlight that throughout the talk, is that most recent trials tested DHA alone with high doses. However, DHA and AA are biologically linked. So they actually share metabolic pathways using the same enzymes. So when we increase DHA, we may actually reduce AA levels, leading to a DHA-AA imbalance. And that raises a critical question. Are we correcting one deficit, the deficit in DHA, while worsening another? And this imbalance might influence inflammation and the development of morbidities. So we will come back to this biological concern as we will discuss about the different trials. So let's move on and let's review this evidence. So first, let's define our clinical question. So we are focusing here on very preterm neonates, those born before 29 weeks of gestation. And the intervention of interest is high-dose DHA supplementation at a dose to approximate what they would have received in neutral, with or without arachidonic acid, or AA. In terms of outcomes, we are looking across major clinically relevant outcomes. So let's focus on one key outcome, bronchopulmonary dysplasia, also called BPD, or the chronic lung disease of prematurity. Why focus on BPD? Well, BPD is one of the most common complications of prematurity, affecting up to half of these infants. And importantly, it is strongly linked with long-term outcomes, including long-term respiratory and neurodevelopmental outcomes. At its core, BPD is driven by inflammation and oxidative stress. And importantly, we have animal studies suggesting that DHA can reduce lung inflammation and improve lung structure. So the question is, can we translate this benefit that we are seeing with preclinical data into clinical benefit in our preterm neonates? So there are two key clinical trials that tested high dose of DHA for BPD in very preterm infants. The first one I'll present is the Moby-Dick trial. The Moby-Dick trial is a large Canadian randomized trial which was led by our group. And we tested a high-dose DHA through maternal supplementation in lactating mothers of neonates born less than 29 weeks. The primary outcome was survival without BPD. However, there was no improvement in BPD. And there was actually a signal towards an increase in BPD in the DHA group. And this increase in BPD in the DHA group was the reason why the Moby-Dick trial was terminated early, when approximately half of the trial participants had been enrolled. So there was a concern for harm. And this was not an isolated finding. A similar signal was observed in the N3RO trial, which is a large, very well-conducted RCT in Australia, also using a high-dose DHA in the same population, neonates less than 29 weeks. The key difference here was the mode of delivery. In the N3RO study, they gave a direct enteral DHA supplementation to the neonates. So after these somewhat surprising and concerning results, we needed to take a step back and look at the broader evidence. And that's where the systematic review comes in. So we conducted a systematic review on high-dose DHA enteral supplementation on BPD in neonates born less than 29 weeks gestation. And what you can appreciate on this slide is that overall, across RCTs, high-dose DHA did not reduce BPD. What you need to know is that there are several different definitions of BPD. And when we looked more precisely at trials using a more rigorous definition of BPD, using a standardized oximetry test at 36 weeks, high-dose DHA was associated with an increased risk of BPD. So what we see is that these results were not consistent across trial, and there was substantial heterogeneity, which is critical. So what we need to realize is that the trials we were comparing were actually testing different interventions, some with DHA alone, some with a combination of DHA and AA. They were also using different modalities of administration, as I mentioned, some with maternal breast milk, others with direct enteral supplementation. And importantly, they also differ in how BPD was defined and sometimes with different population. So I don't want to go through each of these trials. I think it's helpful just to take a step back and look across these studies. So what I tried to do with this table is to summarize the signal on BPD. Green, suggesting a potential benefit. Red, a signal toward an increase in BPD. And white, if there's no clear difference. So what stands out to me is that when we look at studies using high-dose DHA alone, they tend to show a signal toward increased BPD. Whereas when we look at the trials using a combination of DHA and AA, we found no difference in BPD. However, as you can see on the table, these studies were not assessing BPD as the primary outcome. So they were not powered to detect a difference in BPD. Yet the results are clearly not consistent, reflecting again the substantial heterogeneity that we have across trial. And that's why we needed to move to the next step, to an individual participant data meta-analysis, an IPDMA. So when we do traditional meta-analysis, we combine the results from different studies that are not fully comparable. Here we had the problem with different BPD definitions, different intervention, which limits the ability to explore who may benefit from an intervention such as DHA supplementation. With the IPDMA, we can go back to individual patient data with harmonized variables and apply a consistent definition of BPD. So we conducted this IPDMA with a more precise and clinically relevant question. What we wanted to know is what is the effect of high-dose DHA alone on severe BPD? And we used a harmonized, modern, and clinically meaningful definition of BPD based on this publication from Jensen et al. Based on this definition, we know that we were using a severity-based definition that has strong and probably the best prognostic value for long-term respiratory and neurodevelopmental outcomes. So that was something that was very clinically relevant. So two RCTs were identified and were identified as part of the systematic review and met the inclusion criteria for the IPDMA. It was the Moby Dick trial and the entry-RO RCTs that I already presented to you. And in an IPDMA, I think really the key step is harmonization. And this is where the Maelstrom framework really became critical. We don't simply pull data, we harmonize the data. So that means aligning variables, definition, and outcomes across trials to generate one standardized data set that can then be analyzed consistently. So as mentioned, we used the Maelstrom to harmonize the data, which really provided a structured and simple approach. And the most critical step for us was to define a common outcome. So we defined the severe BPD primary outcome, and we were able to apply that to all the data sets. So that way we were addressing one of the biggest limitations of prior study. I'm afraid I will lose my screen if I click on the hyperlink here, but what I want to mention is that it's available online. You can go back to have a list of all the variables. You can see how things matched or not across the different variables. So this information is available for everybody online. So now let's move on to the result of the IPDMA. So in this IPDMA, testing, as we mentioned, high-dose DHA alone on severe BPD in neonates born less than 29 weeks gestation, we do not see an association between DHA and an increased risk of severe BPD, which I want to remind you was really what we considered the clinically significant outcome. So that was somewhat reassuring. However, the risk for any grade BPD was increased in neonates exposed to high DHA compared to placebo. And this finding is consistent with the signals we observed in individual trials. So let's summarize what we know so far. After moving from individual trials to the systematic review and to the harmonized IPDMA, we found in the individual trials that two major high-dose DHA alone trials, Moby and N3RO, did not show benefit for BPD. And in fact, they both raised a signal toward increased BPD. However, let's remind ourselves that the smaller trials testing a combination of DHA and AA showed no difference in BPD. Again, this was not their primary outcome. However, this is something that we need to keep in mind. Second, when the evidence is pulled into systematic review, the overall estimate doesn't support an association between DHA and BPD. However, when we looked at more stringent definition of BPD, we found an association between DHA and BPD. And third, the IPDMA showed us that DHA is not associated with severe BPD. However, if we looked at any grade of BPD, we see that high-dose DHA increased the risk of BPD. So I think the key message here is that high-dose DHA given alone is not a strategy to prevent BPD. And if anything, well, we need to think again about the biology and the intervention design, and we need to think about this DHA-AA balance again. So that was a brief overview of DHA and BPD. But what about the other outcomes that matter? What about the brain? As we previously mentioned, DHA is important for brain growth and maturation, with potential impact on neurodevelopmental trajectory. And from a biological standpoint, there is a strong rationale to expected benefit of DHA on neurodevelopment. So first, let's go back to the data from the two key clinical trials. In Moby, which used maternal supplementation to enrich breast milk in DHA, there was no overall difference on neurodevelopment at either 18 to 22 months or at 5 years. However, there were signals of benefit in specific subgroups, particularly in neonates born earlier, so those born less than 27 weeks, and possibly in females as well. In contrast, in the N3RO trial, which used direct enteral DHA supplementation, there was no overall difference at 2 to 3 years, but at 5 years, there was a significant increase in IQ, about 3.5 points, suggesting benefits of DHA on cognitive development. So the next step was to conduct again a systematic review, which we did. And what we are looking at here is the meta-analysis assessing high-dose DHA on neurodevelopment in less than 29 weeks gestation at 4 to 8 years of age. And what we can see here at the bottom of the slide is that high-dose DHA was not associated with a significant effect on cognition. It's crossing the zero line here. However, they are clearly a signal toward benefit in the DHA group, as you can see where the diamond is lying here. In addition, in our secondary outcomes, we found a reduction in mild cognitive impairment. So how do we summarize these findings? First, although we see some benefits of DHA in specific subgroups, we do not see a consistent positive effect of DHA on neurodevelopment. I think it's important to remind ourselves that the literature is highly heterogeneous. The exposure is different, with some studies that use direct enteral DHA versus maternal DHA, and neurodevelopmental outcomes also differ, both in timing and in what aspect of neurodevelopment is being tested. But when we look more closely, I think there are several signals suggesting potential benefits of DHA for neurodevelopment. Some benefits may appear in specific subgroups, such as the most immature neonates, the females, and might depend on the mode of delivery. And I think one thing that we need to highlight is that one important limitation of the current evidence is that these neurodevelopmental studies have largely evaluated DHA alone. The role of combined DHA with AA, which may be biologically important, remains largely untested on neurodevelopmental outcomes. So the key message here to me is that effects of DHA on brain and neurodevelopment are heterogeneous, but we see some potential benefits, and these are context dependent. So far we focused on DHA in relation to the lungs, to the brain, and we will now focus on the eyes, because DHA is also critical for eye development. In preterm neonates, the normal retinal vascularization might be disrupted. And this can lead to abnormal vessel growth, as you can see on the picture on the right. When we have this abnormal vascular growth in the vessels of the eyes, we call that retinopathy of prematurity, or ROP. And this is important as when it's severe, it may result in visual impairment and blindness. And DHA and arachidonic acid are key components of retinal membranes and play key roles in inflammation and oxidative stress pathways, making them highly relevant to ROP. So the next question, and the last for today, could optimizing DHA and potentially that balance between DHA and AA might influence the risk of retinopathy of prematurity? And the MEGA-DONA-MEGA trial gave us some very interesting answer. In this randomized trial, combined DHA and AA supplementation was given to neonates born less than 28 weeks gestation. And the intervention was associated with a substantial reduction in severe retinopathy of prematurity, with about a 50% relative reduction in severe BPD, in severe ROP, I'm sorry. So very interesting data. Now, when we take a step back and look across studies, we find that for studies using DHA alone at the top of the slide here, we found no clear reduction in ROP. However, when DHA is combined with AA, we see a signal toward a reduction in ROP risk. So this is a summary of what we discussed so far. In brief, when we look at the lungs for respiratory outcome, we found that high dose DHA alone was not associated with an improvement in BPD and may actually increase the risk. Whereas there was no difference when we look at studies combining DHA and AA. Now, for the brain, for the neurodevelopment, what we found is that the effects are heterogeneous. However, we have a lot of signals suggesting benefits for the brain in specific subgroups and according to the way the DHA was provided to the babies. And for retinopathy or eye outcomes, there was quite convincing benefits in the most recent trial assessing the combination of DHA and AA for severe IOP. However, again, when we look at systematic review and we pull everything together, we don't see a consistent effect. So now, why do we see inconsistent results? As we have highlighted throughout the talk, I think this is largely driven by heterogeneity across trials. As we mentioned, there are major differences in the interventions in terms of dose, formulation, timing, and importantly, whether DHA was given alone or in combination with AA. And second, there are important differences in how outcomes are measured, with variability and lack of standardization, particularly for outcomes like BPD and neurodevelopment. So it's not that surprising that the results don't align as we are testing different things in reality. So what do we do with the data that we have and where are we going? Well, I think the field is clearly shifting. Although there was a strong biological rationale for high-dose DHA, I think we are moving away from that idea that more DHA is better for everyone. I think what the data is showing now is that effects depend on dose, timing, this DHA-AA balance, and patient characteristics. So I believe the next step should be oriented toward precision nutrition with the right nutrient given with the right balance to the right patient. There are still knowledge gaps that need to be addressed. What is the optimal dose and timing for the different subgroups? In terms of the population, do sex, gestational age, or growth restriction will modify the effect of the intervention? In terms of the measurement, what type of outcomes should we use? How do we standardize outcomes across the different trials that will occur over the next few years? And which biomarkers can guide this individual supplementation? And I think this clinical trade-offs is important to consider. How, as a research and clinician community, how do we balance these short-term pulmonary risks with the benefits on eye development and brain development and long-term neurodevelopmental outcomes? So where do we go from here? Well, I believe that first, we need to move beyond DHA alone and test this balanced DHA-AA strategy. Second, I think we need larger, well-powered trials focusing on the neonates that will most likely benefit from the intervention. And third, I think one of the things that was missing in the previous trial is to better integrate biology using biomarkers and understanding this DHA-AA balance. And finally, we need to align outcomes with harmonized definitions and a more integrated view of the different organs, including the lung, the brain, and the eye. So I'm quite convinced that this is not the end of the DHA story. I think these trials really have moved the field forward, bringing us closer to understanding how early nutrition can shape outcomes in the very preterm population. So I'm truly excited about the next steps, and I hope that I can come back in a few years and share with you some more definitive and exciting results. So on this note, thanks again for inviting me today. Sincere thanks to my research team and to all the participating families. And I'll be happy to take questions. I also included my email. If you have questions, comments, I'll be happy to address your questions and clarification through my email as well. So thank you. I'll stop sharing my screen so I can see you if you have questions.
Dr. Smith has a question if he wants to go ahead.
Hi. Thanks so much, Mireille. Thanks, Susan. My name's Ben. I'm from the Research Institute at McGill. Thanks so much for giving this talk. So I had a couple of questions, and I'm not a neonatologist, so excuse if they're very ignorant. But the heterogeneity and the potential benefits across the different organ systems was interesting. So one question is, do all of those adverse outcomes tend to occur in the same patients, or is it possible to identify people more at risk towards neurodevelopmental adverse outcomes versus the BPD outcomes? Is one question. And the second question is whether people have looked into targeting the neonates who are deficient rather than giving it to all the neonates, or is it just known that they're all deficient? So first question is just the heterogeneity of the outcomes, and the second is whether one should target kids who are deficient versus everyone.
Thank you for your question. So for the first question, whether we can identify a subgroup at higher risk of adverse outcomes after the intervention, I don't think we have this data. And I think what was quite reassuring for us in terms of the lungs outcomes, because that's the main thing. If DHA increase BPD, the lung disease, even if it's improving the brain outcomes, should we keep going? And I think one of the things that I want to emphasize is that the IPDMA showed that when we look at what we consider significant in terms of BPD, severe BPD, there was no association between DHA and severe BPD. But that would be an interesting question to look at those specific neonates that had BPD. What do they have in common? And do they have characteristics that go above what we usually know in terms of who are at risk of BPD? Now, regarding your question, remind me what's your second question again?
Well, in nutritional epidemiology is a challenging field, so I congratulate you for pursuing it. But in other supplementation trials and studies, a question that often comes up if a trial is negative or positive, or if there's heterogeneity, is whether one should be targeting the supplementation to the subset of people who are actually deficient in whatever the supplement is trying to raise,
Yeah.
or if just giving it to everyone. And so I guess I just don't know, in these very preterm infants, is it reasonable to assume that they are all massively deficient in DHA or AA, or is there some variability in that?
Yeah, that's a good point. Well, we do have studies showing this deficit that they have. So in general, it's a known fact that they are DHA and AA deficient. But your question raises a good point. Because it's probably not a one size fits all. We should probably be moving towards what you're suggesting, this precision nutrition intervention, and adapt maybe the intervention to the needs of these individuals. So I think that's a moving field, and that's something that is getting more and more interest to adapt the intervention according to the one individual in front of us. And of course, the levels of DHA and AA will vary across the different neonates born very preterm, and maybe we should adapt our intervention. So that's something that is certainly emerging in the neonatal nutrition field, and that we will have to look into and see how can we better target the neonates that really need this supplementation.
Thanks.
I don't know if anyone else on Zoom has a question. I know there is one in the chat. It is quite long. I'm not sure if you want me to read it out.
I'm looking at it now.
Could you summarize it slightly for the YouTube audience
I
who can't
think
read it?
Morgan is raising this problem that we have in neonatology regarding the definition of BPD. As she's mentioning, so in the population we included in our study, we are looking at neonates born very preterm, those born less than 29 weeks. But what we need to know is that a baby born at 27 weeks, for example, is very different in terms of development from a baby born at 23 or 24 weeks. So that's what Morgan is mentioning. What type of definition should we use to really account for this developmental long process that might be different in a baby born closer to 29 weeks as opposed to a baby born much earlier? And what we did in the IPDMA, at least, is that we used what is described in the literature right now as the most predictive definition of BPD. We use the one described by Jensen and try to identify severe BPD based on this definition. So we had data on what type of ventilation support and oxygen the babies were on at 36 weeks, and that's how we defined BPD. However, I agree with Morgan that this is still insufficient in terms of BPD definition, and I think it's still a problem to be able to find the right definition for the outcome of BPD. And I think the community is working on that. We're trying more and more to better understand BPD and to define BPD not only on the type of mode of respiratory support that the baby is on or the oxygen that the baby is on, but with more specific biomarkers that can better represent this pulmonary disease that our preterm neonates have. So to answer the question quickly, what we use is the Jensen definition. We did not modify the definition according to the gestational age of the baby. But again, I think the BPD definition is a recurrent problem that we've been having in neonatology for years. And we are still looking for the perfect definition for BPD.
I see here that there's no questions over at McGill. Are there any other questions from our Zoom audience? Going once, going twice. Last chance. That would seem to be it for questions for today. Thank you so much for joining us.
And again, I'm available through my email. If you guys have questions or want to discuss about the findings, I'll be more than happy to connect with you. Thank you very much again for the invitation.
Thank you for being here. And I invite everyone to join us again on Wednesday for our Solve the Stay campaign seminar. See you then.